Let's begin by understanding the term prognosis. Prognosis refers to the prediction of the probable course, duration, and outcome of a disease. This prediction is based on general knowledge of how the disease develops and the presence of risk factors. Importantly, prognosis is determined after a diagnosis is made but before a treatment plan is established. Many people confuse prognosis with risk, but they are not the same. Prognosis is about what happens after a disease is present, while risk is about the likelihood of developing the disease in the first place. Throughout this video, we'll explore the nuances of prognosis, especially in the context of periodontal diseases. It's crucial to distinguish between prognosis and risk. Prognosis predicts the likely outcome and response to treatment once a disease is present. In contrast, risk deals with the probability of developing a disease based on certain factors. For example, being a smoker or having diabetes increases your risk of developing periodontal disease. Once the disease is present, those same factors can also indicate a poorer prognosis. Understanding this difference helps clinicians make better decisions when planning treatment and counseling patients. Prognosis is established after a diagnosis has been made but before the treatment plan is put into action. This timing is important because it allows the clinician to assess all relevant factors, such as the severity of the disease, patient cooperation, and the presence of systemic or environmental influences. By determining prognosis at this stage, the dental team can set realistic expectations and tailor the treatment plan to the patient's specific needs. Prognosis can be categorized into several levels: excellent, good, fair, poor, questionable, and hopeless. Each category reflects the likelihood of disease control and tooth retention. For example, an excellent prognosis means no bone loss and good patient cooperation, while a hopeless prognosis indicates advanced bone loss and the need for extraction. These categories help guide treatment decisions and patient communication. Before finalizing a treatment plan, it's often advisable to establish a provisional prognosis. This temporary assessment allows for initial therapy to begin, such as scaling and root planing, and for the patient's response to be evaluated. After this phase, the prognosis can be re-evaluated and adjusted based on how well the patient responds to initial treatment and oral hygiene instructions. Several classification systems exist to help clinicians determine prognosis. One widely used system, proposed by Kwok and colleagues, classifies teeth as favorable, questionable, unfavorable, or hopeless. These categories are based on the probability of disease progression and the ability to control local and systemic factors. The hopeless category signifies that extraction is necessary. A favorable prognosis means that periodontally affected teeth can be stabilized with comprehensive periodontal treatment and maintenance. In these cases, future loss of periodontal tissues is unlikely, provided that the patient maintains good oral hygiene and attends regular follow-up appointments. This category is the goal for most periodontal therapies. A questionable prognosis is assigned when the periodontal status of a tooth is influenced by local or systemic factors that may or may not be controlled. If these factors can be managed, the tooth can be stabilized with treatment and maintenance. However, if they cannot be controlled, future periodontal breakdown is likely. This category requires close monitoring and patient cooperation. An unfavorable prognosis is given when local or systemic factors cannot be controlled, even with comprehensive periodontal treatment and maintenance. In these cases, periodontal breakdown is likely to occur, and the long-term retention of the tooth is doubtful. The focus may shift to palliative care or planning for eventual extraction. A hopeless prognosis means that the tooth must be extracted. This is usually due to advanced bone loss, non-maintainable areas, or uncontrolled systemic or environmental factors. Attempting to retain such teeth can negatively impact the health of adjacent teeth and overall oral function. Extraction is recommended to prevent further complications. Determining prognosis involves evaluating a range of clinical, environmental, and restorative factors. Clinical factors include patient age, disease severity, pocket depth, attachment level, and bone loss. Environmental factors encompass smoking and systemic diseases, while restorative factors relate to the condition of existing dental work. All these elements are considered together to form a comprehensive prognosis. Patient age plays a significant role in prognosis. For two patients with similar levels of bone and connective tissue attachment, the older patient often has a better prognosis. This is because the same amount of destruction over a longer period suggests a slower disease progression. In younger patients, rapid destruction may indicate a more aggressive disease, leading to a less favorable prognosis. The severity of periodontal disease is determined by assessing pocket depth, attachment level, bone loss, and the type of bony defect. These factors are evaluated through clinical examination and radiographs. More severe disease, especially with deep pockets and significant attachment loss, generally leads to a poorer prognosis. However, the relationship between pocket depth and bone loss is not always straightforward. Pocket depth is an important clinical measurement, but does not always correlate directly with bone loss. A tooth with deep pockets but little attachment and bone loss may have a better prognosis than one with shallow pockets but severe attachment and bone loss. The location of the pocket base, in relation to the root apex, also influences prognosis, especially if apical disease is present. The degree and type of bone loss are critical in prognosis determination. Horizontal bone loss prognosis depends on the remaining bone height, while angular or intrabony defects depend on bone contour and the number of osseous walls. Vertical defects often have a better chance for regeneration compared to horizontal defects. The distribution of bone around the tooth also affects mobility and force distribution. Plaque is the primary cause of periodontal disease. Effective removal of plaque is essential for successful periodontal therapy and a favorable prognosis. Both the patient and the clinician play roles in maintaining plaque control through regular cleaning, professional maintenance, and patient education. Patient cooperation is a key determinant of prognosis. The willingness and ability to maintain good oral hygiene, attend regular checkups, and follow professional advice greatly influence treatment outcomes. If a patient is unwilling or unable to comply, the prognosis worsens, and certain treatments may not be recommended. Smoking is the most significant environmental risk factor for periodontal disease. It not only increases the risk of developing periodontitis, but also worsens the prognosis for those already affected. Smoking impairs healing and increases the severity of disease. However, quitting smoking can improve prognosis, especially in cases of slight to moderate periodontitis. Systemic diseases, such as diabetes, significantly affect periodontal prognosis. Well-controlled diabetics with good oral hygiene can have a good prognosis, while uncontrolled diabetes makes the prognosis questionable, especially when surgical treatment is needed. Other systemic conditions, like Parkinson's disease, may require special oral hygiene aids to improve outcomes. Genetic factors can increase the risk and severity of periodontal disease. For example, certain interleukin-1 gene polymorphisms are linked to more severe periodontitis. Early detection of genetic risk can guide preventive strategies and influence treatment recommendations, such as the use of adjunctive antibiotics. Family history is also important, especially in aggressive periodontitis. Physical and emotional stress, as well as substance abuse, can negatively affect the body's response to periodontal treatment. These factors may compromise healing and make it harder to achieve a favorable prognosis. Addressing these issues is an important part of comprehensive care. Plaque and calculus are the most important local factors in periodontal disease. Their removal is essential for a good prognosis. Both the patient and the dental team must work together to eliminate these etiological factors through effective cleaning and maintenance. Subgingival restorations, such as overhanging fillings, can increase plaque accumulation, inflammation, and bone loss. The size and duration of these discrepancies influence the amount of destruction. Teeth with poorly contoured subgingival margins generally have a poorer prognosis than those with well-contoured margins. Certain anatomic factors, such as short, tapered roots, large crowns, cervical enamel projections, and root concavities, predispose teeth to periodontal disease and make cleaning more difficult. These features can reduce the available root surface for support and increase the risk of disease progression, leading to a poorer prognosis. Furcation involvement refers to the loss of bone between the roots of multi-rooted teeth. This condition makes cleaning difficult and increases the risk of tooth loss. The prognosis worsens as the degree of furcation involvement increases, especially if access for cleaning is limited. Teeth that serve as abutments for prostheses are subjected to increased functional demands. Abutment selection, the presence of caries, non-vital teeth, and root resorption all influence prognosis. Special oral hygiene measures may be needed to maintain these teeth and ensure the success of prosthetic treatments. Extensive root resorption, whether idiopathic or due to orthodontic therapy, jeopardizes tooth stability and negatively affects the response to periodontal treatment. However, new attachment can occur to both vital and non-vital teeth, so careful assessment is needed before making a prognosis. Prognosis can be divided into overall and individual tooth prognosis. Overall prognosis considers the entire dentition and addresses questions like whether treatment should be undertaken and if it's likely to succeed. Individual tooth prognosis is determined after the overall prognosis and is influenced by local factors affecting each tooth. Several factors influence the overall prognosis, including the patient's age, systemic health, presence of plaque and calculus, patient compliance, and smoking status. The ability of the remaining teeth to support prosthetic replacements is also considered. These factors help determine whether treatment is likely to succeed. Tooth mobility is mainly caused by loss of alveolar bone, inflammation, and trauma from occlusion. Mobility due to inflammation or trauma may be reversible, but mobility from bone loss is usually permanent. Stabilizing mobile teeth with splints can sometimes improve prognosis. Individual tooth prognosis is affected by local factors such as plaque, calculus, subgingival restorations, anatomic variations, caries, non-vital teeth, root resorption, and mobility. These factors are assessed after the overall prognosis and help determine the best course of action for each tooth. To summarize, prognosis is the prediction of the probable course, duration, and outcome of a disease. It is established after diagnosis and before treatment planning. Prognosis can range from excellent to hopeless and is divided into overall and individual tooth categories. Key factors include clinical, environmental, and local considerations, as well as patient compliance and prosthetic needs. Factors such as patient age, disease severity, genetic susceptibility, and systemic disease are important for both diagnosis and prognosis. These criteria help clinicians not only identify the condition, but also predict its likely course and outcome, guiding treatment planning and patient counseling. For patients with gingivitis caused by dental plaque, the prognosis is generally good if all local irritants are eliminated and the patient maintains good oral hygiene. Systemic factors, such as hormonal changes or blood disorders, can modify the prognosis, making control of both plaque and systemic factors essential. Certain medications such as phenytoin, cyclosporin, and nifedipine can cause gingival enlargement. In these cases, plaque control alone is not enough, and surgical intervention may be needed. Continued use of the medication can lead to recurrence, so prognosis depends on whether alternative drugs can be used. Malnutrition is not a major cause of gingival disease, but severe or prolonged deficiencies can affect prognosis. Reversing the deficiency through dietary supplementation may improve outcomes, but the overall impact is usually limited compared to other factors. Non-plaque-induced gingival lesions can result from bacterial, fungal, or viral infections. The prognosis in these cases depends on eliminating the source of infection. Prompt and targeted treatment is essential for a favorable outcome. The prognosis for periodontitis varies depending on the type and severity of the disease. Chronic periodontitis progresses slowly and is often associated with local factors, while aggressive periodontitis progresses rapidly and may have a genetic component. Early diagnosis and appropriate therapy can improve prognosis, especially in localized aggressive cases. Periodontitis can be a manifestation of systemic diseases such as hematological or genetic disorders. In these cases, the prognosis is mainly dependent on the management of the underlying systemic condition. Effective control of the systemic disease can improve periodontal outcomes. Necrotizing periodontal diseases, such as NUG and NUP, are complicated by factors like stress, smoking, and poor nutrition. Prognosis is good if both bacterial plaque and secondary factors are controlled. In more severe cases, addressing systemic problems is also necessary for successful management. Chronic periodontitis is slowly progressive and often responds well to conventional therapy if detected early. Aggressive periodontitis, however, progresses rapidly and may require systemic antibiotics and regenerative therapy. Prognosis is better in localized cases diagnosed early, while generalized cases often have a poorer outlook. After initial Phase 1 therapy, prognosis should be re-evaluated. A reduction in pocket depth and inflammation indicates a favorable response and better prognosis. If there is little improvement, the overall prognosis may be less favorable, and alternative treatments should be considered. In summary, prognosis is a dynamic assessment that guides treatment planning and patient expectations. It is influenced by a combination of clinical, environmental, and local factors, as well as patient compliance and systemic health. Regular reevaluation ensures that the prognosis remains accurate and relevant throughout the course of treatment. Remember, prognosis is not static. It should be reassessed at every stage of treatment, especially after initial therapy. Patient education, motivation, and regular follow-up are essential for improving prognosis and achieving long-term periodontal health. Prognosis is a cornerstone of periodontal care, shaping treatment plans and patient expectations. By understanding and applying the principles of prognosis determination, clinicians can provide better care and help patients achieve optimal oral health. Thank you for joining us on this comprehensive journey through prognosis in periodontal disease.